lot of people say, for patients with instrumented spine, just easy. If they have laminectomy, the lamina is removed anyway. Just makes the spinal easier. Just go midline and you should be good to go. I would argue that that might not be the most nuanced or safe approach, and I'll illustrate why with this example. This is a patient that I met previously, L4, L5 laminectomy history, and L3 to S1 screw rod fixation. When we scan the patient, this is what you would see. Keep in mind that the lamina have been removed, and therefore you cannot count spaces based on the PMO view. So what you need to do is to count based on ribs. So you go from the T12 rib and scan a bit more medially, and you will get the T12, L1, and L2 transverse processes. And when you scan a little bit more caudal, then you get the T12, L1, and L2 transverse process. And you scan a bit more caudal, you get the L1, L2, L3 transverse processes. And finally, a bit more caudal from that, you get the L3, L4, and L5 transverse processes. Okay, now you get the correct level. You start scanning medial, then you get the reverberation artifacts coming in with the screw. I overlaid the MRI image and turned it 90 degrees for better comparisons. If you scan it just a bit more medial, you will get the reverberation artifacts from the rod, okay, and then the screws. And then you scan a bit more medially from that, then the thecal sac will start to come into view. But what's that just superficial to the thecal sac? That is a pseudomeningeal seal, just superficial to the thecal sac. So imagine that you don't review the patient's imaging, you don't perform the ultrasound scanning, and you just go midline and straight in. You might get CSF back, but your spinal anesthesia is not going to work if you inject into the pseudomeningeal seal. And even more importantly, based on MRI imaging, there are arachnoiditis associated with the pseudomeningeal seal, increasing possibly the chance of neurologic damage with spinal anesthesia.